Welcome again in a new session of General Toxicology. We'll talk today about enhancement of elimination. I'm Dr. Duail Gharabawi. Today we will talk about meaning, indications, and methods of enhancement of elimination in a toxicological patient. What is meant by enhanced elimination? It means to increase rate of removal of poison from the blood after being absorbed. We all know that any substance that enters the body will be eliminated with a normal rate of elimination. However, in acute toxicity, I need to increase this rate of elimination to get rid of this toxin outside the body rapidly. That's why to improve the condition of the acutely poisoned patient. Indications for enhanced elimination depends on factors related to patient and factors related to poison. The factors related to patient include a patient who is critically ill, especially if he is unresponsive to supportive care. Also, I need enhanced elimination in a patient with impaired usual route of elimination. For example, if a patient took a drug or a toxin and this toxin is eliminated through kidney and this patient suffers from renal failure, so this toxin will not be eliminated from the body except I use one of the enhanced elimination methods. Also, I need enhanced elimination in a patient seriously ill and complicated with one of life-threatening complications such as acid-base disturbance or electrolyte disturbance or whatever, especially if these disturbances are resistant to treatment. On the other hand, the factors related to the poison include ingestion of a known lethal dose of the drug or the toxin. When my patient gives a history that he ingested a lethal amount of the toxin, or actually when I do investigation to my patient and found a lethal blood level of the drug, here I need to do enhancement of elimination. But not all poisons can be eliminated by one way. So there is some criteria for each poison to be eliminated by certain method of enhanced elimination. And this criteria will be mentioned later on with each method of enhanced elimination. Methods of enhanced elimination depends on the normal route of elimination of poisons. For example, I can enhance elimination of poisons normally eliminated through lung by increasing rate and depth of respiration. While poisons normally eliminated through bile, I can use multiple doses activated charcoal to enhance its elimination. Most of poisons in our body are normally eliminated through kidney. So, I have to ask myself, is this patient has a normal kidney function? If yes, I'll depend on his kidney to increase the elimination of the poison, which is called diuresis. But if he has impaired kidney function, so I'll depend on other method rather than his diseased kidney, which is called dialysis. We will start with diuresis. There are some criteria for effective diuresis. These criteria include that the patient has normal renal function. This is the most important one because I depend on his normal kidney function to enhance elimination of the poison. Also, there are some criteria should be present in the poison to be effectively eliminated through diuresis. These criteria include to be normally excreted in urine. This is the normal route of elimination of the poison. To have low volume of distribution. to be available in the blood, not widely distributed intracellular. Also, to have low plasma protein binding. I need it to be present in the blood in a free form, not in plasma protein binding form, to be easily eliminated. There are different types of diuresis, like fluid diuresis, where I just increase the amount of intravenous fluids entering the body to increase the urine volume and concurrently increase the amount of toxin normally eliminated with the urine outside the body. But it's used only or effective only in mild poisoning. Also, we have osmotic diuresis, where I inject a substance like mannitol 25% intravenously to be excreted in renal tubules, where it increases the osmotic pressure inside the renal tubules and increasing the urine volume. Also, it will increase the amount of the toxin normally excreted with the urine outside the body, but also it's effective only in mild poisoning. The most important type of diuresis is forced diuresis, which may be called ion trapping or urine pH manipulation, because it's effective in moderate and severe poisoning. It has two types: alkaline diuresis to increase rate of elimination of weak acidic drugs, and acidic diuresis, which was used to increase rate of elimination of weak basic drugs. However, they found that acidic diuresis is not sufficiently effective in elimination of weak basic drugs and have many complications. So it's not used nowadays and forbidden, and we will not talk about it. Let's explain the mechanism of action of alkaline diuresis through ion trapping. We will take barbiturate as an example for weak acidic drug. The normal rate of elimination of barbiturate outside the body shown here. The barbiturate will be excreted from blood to renal tubular lumen, where the urine is an acidic pH. So a large amount of barbiturate will be present in non-ionized form, and a small amount will be converted into ionized form. The non-ionized form is characterized by being highly lipid soluble, so it will cross the cell membrane and will be reabsorbed back to the circulation. However, the small amount of barbiturate present in ionized form is less lipid soluble and can't cross the cell membrane, so it will be trapped in the renal tubular lumen and pass outside the body with urine. This small amount of ionized form of barbiturate, which is eliminated from the body, represents the normal rate of elimination of barbiturate outside the body. Okay, now let's see what happens when we change the pH of the urine from acidic to alkaline media by injecting an alkaline substance like sodium bicarbonate intravenously. The barbiturate will be excreted from the blood to urine, where it finds the alkaline media of the urine. So a large amount of the barbiturate will be changed from non-ionic form to ionic form, and very small amount will be in non-ionic form. This very small amount in non-ionic form of barbiturate will be reabsorbed again and returns back to the circulation, while the most of barbiturate that present in the ionized form will be trapped in the renal tubular lumen to be excreted outside the body with the urine. Therefore, we increased the elimination of a weak acidic drug like barbiturate by changing the pH of the urine from acidic to alkaline media. That's why we call alkaline diuresis urine pH manipulation. When we did that, we converted the non-ionic form of the barbiturate to the ionic form, which is trapped in the renal tubules and excreted outside the body. That's why we call it ion trapping. To do an effective alkaline diuresis, I need to maintain the urine pH at or more than 7.5 up to 8 and the blood pH at 7.5 up to 7.6. How can I do that? By using mannitol intravenously to increase osmotic pressure inside the renal tubular lumen, intravenous sodium bicarbonate as an alkaline substance to change the pH of the urine from acidic to alkaline media, and intravenous fluids to induce diuresis. Before I start the session of alkaline diuresis, I have to do the following investigations. Number one, to do renal function tests for your patient to be sure that it's normal. Also, I do serum electrolytes to maintain it normal, and serum pH, urinary pH, and also to do serum drug concentration to be sure that it's a toxic level. Now I can start the alkaline diuresis session, but during the whole session, I have to monitor the serum electrolytes to maintain them normal, urine pH to be at 7.5 up to 8, and blood pH to be at 7.5 to 7.6. This is how we maintain an effective alkaline diuresis session. We have to be very careful during calculating the doses of mannitol, sodium bicarb, and fluids used for alkaline diuresis to avoid complications. For example, if I used excess amount of sodium bicarbonate, the excess sodium may cause electrolyte disturbance in the form of hypernatremia, hypokalemia, and hypocalcemia. Also, the bicarb of the sodium bicarbonate may lead to alkalemia. If I used excess intravenous fluids, the patient may suffer from fluid overload. Excess intravenous mannitol may lead to dehydration. What are the contraindications of diuresis? Maybe the poison doesn't fit for effective diuresis by being not excreted mainly in urine, or has large volume of distribution, so it doesn't present in the blood but mainly widely distributed intracellular, or highly bounded to plasma protein, so it doesn't present in the blood in a free form. Also, the patient may suffer from renal dysfunction or any disease related to fluid overload like heart failure, pulmonary edema, or cerebral edema, or maybe shock. If the person and the patient fit for diuresis, but I don't have a qualified lab to always monitor serum electrolytes, blood pH, and urine pH, I can do diuresis. Now we will talk about dialysis. The principle of dialysis is a passive diffusion of substances along concentration gradient. For example, we allow the blood with the higher toxic concentration to be on one side of a semi-permeable membrane, and on the other side of the semi-permeable membrane, we put a clean dialysate fluid. So the concentration of the toxins now is higher in the blood and doesn't present in the dialysate fluid. So the toxin will pass diffused passively from the blood to the dialysate fluid through a semi-permeable membrane. The toxins will diffuse from the higher concentration, which is the blood, to the lower concentration, which is the dialysate fluid. This passive diffusion will continue until there is equilibrium in the toxic concentration between blood and dialysate fluid. Now, if I get rid of the contaminated dialysate fluid and replace it with a new clean dialysate fluid, the toxins will be higher concentration in the blood than the dialysate fluid, and will repeat the process, will passively diffuse from the blood to the dialysate fluid through the semi-permeable membrane until equilibrium. When to do dialysis? Who is the patient that needs dialysis? As mentioned before, the severely poisoned patient unresponsive to supportive treatment or suffering from impaired route of elimination, here suffering from renal failure, or complicated with resistant acid-base disturbance or electrolyte disturbance. But also, what are the criteria for the poison to be effectively removed by dialysis? The poison should have small volume of distribution to be present in the blood, not widely distributed intracellular, to have low plasma protein bound, to be present in the blood in a free form, and for the poison to pass through semi-permeable membrane, it should have low molecular weight, low lipid solubility, and high water solubility. There are two types of dialysis, hemodialysis and peritoneal dialysis. Hemodialysis, if I used an artificial semi-permeable membrane, it's called hemodialysis. But if I used the peritoneum as a physiological semi-permeable membrane, it's called peritoneal dialysis. But peritoneal dialysis is a too slow process, so I can depend on it in rapid removal of the toxin, especially in severely ill poisoned patient, where I need to immediately eliminate the toxin from the body to improve his condition. Hemodialysis. To perform hemodialysis, I insert a large bore double-way catheter in a large vein like femoral vein, subclavian vein, or internal jugular vein. Then the blood is pumped outside the body to enter to the hemodialysis machine. Inside the hemodialysis machine, the blood passes through tubes. These tubes are immersed in dialysate fluid, and the wall of these tubes is formed of semi-permeable membrane. Now, the concentration of the toxins inside the blood, which passes inside the tubes, is higher than outside the tubes which contain the dialysate fluid. So, the toxins will passively diffuse from inside the tubes, which contain the blood, to outside the tubes, which contain the dialysate fluid, through the semi-permeable membrane of the tube walls. To maintain this process to continue, I have to get rid from the contaminated dialysate fluid and replace it with warm, clean dialysate fluid all the time. After that, the blood returns back to the body through the other way of the double-way catheter. To avoid coagulation of the blood inside the tubes, I have to use an anticoagulant agent like heparin. There are some contraindications for hemodialysis related to the patient, including unstable hemodynamic, active hemorrhage, or coagulopathy. For the poison, if it doesn't fulfill the previously mentioned criteria to allow it to be effectively eliminated by hemodialysis, then it's contraindicated to do hemodialysis. What are the complications of hemodialysis? There are some general complications like infection at the site of catheter insertion and thrombophlebitis. Also, hypotension, excess heparin may lead to hemorrhage, transmission of blood-borne diseases like hepatitis B virus or hepatitis C virus and AIDS. Also, there are some special complications related to the site of catheter insertion. For example, the insertion of a catheter in a femoral vein may make the patient doesn't move his leg well, which may lead to deep vein thrombosis formation. Tough insertion of the catheter into subclavian vein may injure the apex of the lung, causing pneumothorax. As well, Tough insertion of the catheter into the internal jugular vein may injure the artery, causing air embolism, and the patient may die. Another method of enhanced elimination is called charcoal hemoperfusion. It's so close to hemodialysis, but with some differences. As hemodialysis, we insert a large bore double-way catheter in a large vein like femoral vein, and the blood will be pumped outside the body to enter charcoal hemoperfusion cartridge. In charcoal hemoperfusion, we allow the blood to pass through a cartridge coated with adsorbent material like activated charcoal, to which the toxic agents will be adsorbed, and the blood will return back to the body through the other way of double-way catheter, but with less amount of toxins. Also, we use here anticoagulant agent like heparin. So the criteria that must be present in the poisons eliminated by charcoal hemoperfusion is only two criteria. Number one, to be adsorbed to activated charcoal, and to be present in the blood, so it must have low volume of distribution. Charcoal hemoperfusion doesn't depend on the drug size, water solubility, lipid solubility, or plasma protein binding. Charcoal hemoperfusion sessions can be used in series with dialysis if the patient requires that. As we mentioned, we need to use anticoagulant agent to prevent coagulation of the blood. The process of charcoal hemoperfusion will stop when charcoal is saturated, so I have to change the cartridge with a new clean one. Complications of charcoal hemoperfusion are the same as hemodialysis because they have the same process. In addition to them, activated charcoal can absorb many components from the blood. For example, it can absorb platelets, causing thrombocytopenia. If it absorbed white blood cells, it causes leukopenia. Also, it may absorb calcium, causing hypocalcemia, or glucose, causing hypoglycemia. If part of activated charcoal is detached and returns back with the blood to the body, it causes charcoal embolism. Let's summarize. We have talked in our sessions about decontamination and enhanced elimination. We know now that there are different methods of decontamination, including skin, eye, lung, and GIT decontamination. To enhance elimination of toxins, this depends on the normal route of elimination of the poison. So poisons eliminated normally through lung can be enhanced by increasing rate and depth of respiration. Toxins eliminated through bile can be enhanced by using multiple doses activated charcoal, and most of poisons are eliminated through kidney. So if my patient has normal kidney function, I'll use diuresis with its different types according to the severity of poisoning. And if he has impaired kidney function, I'll use dialysis, especially hemodialysis in clinical toxicology, and charcoal hemoperfusion. Thank you.